All right, good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. My name is Kathy Caudill. I'm a communication specialist with Quality Insights. Today we'll be having a Q&A on the recent regulation updates plus other topics related to long-term care facilities. We'll open with pre-submitted questions and frequently asked questions. If you have a question for our panel, you can submit it using the chat or the Q&A tool. And if you would like to ask your question out loud, you can raise your hand to request to be unmuted. We invite you to join us every Wednesday at 2 p.m. for more webinars in this series. Next week, we'll be discussing post-COVID syndrome in the outpatient and nursing home settings. And now I'd like to briefly introduce today's panelists. We have a few of our quality improvement specialists here today, Deborah Wright, Penny Imes, and Shirley Sullivan. We're also joined by our infection preventionist, Jennifer Brown, and Quality Insights Medical Director, Dr. Jean Storm. And I have lost my questions. I thought I added it here, so just take me 1 second while I pull it up. Here we go. All right, here's the first question. Are there changes coming to NHSN reporting?
So I can take that one. So NHSN recently has completed their educational sessions on their new quarterly changes. They said that we would see these changes starting this week, and I did go into NHSN today, and the changes are there. So they did start this week. So at this point, only changes affecting the surveillance pathways has been instituted. The vaccination module has not been changed yet, although those trainings have been posted and will be next week. So I'm sure we'll see more to come on that. But getting back to the surveillance pathway modules, a lot of things were removed, but there were a couple things that were added. So first, in that first tab, that resident impact and facility capacity section, testing availability, influenza, supplies and PPE shortages, that has all been removed. They also removed admissions admitted with COVID-19, but they did keep a positive test. But with that, if you have a positive test, they did remove most of the vaccination status variables. They did keep residents being up to date with their vaccination statuses if they're COVID positive. So if they're positive, you're going to say if that COVID positive resident is up to date, and then it will do the math and auto-populate for those that are not up to date based on your answer for the up-to-date question. Keep in mind for this particular question, they do have a slightly different definition for up-to-date, and it has to be that the vaccination, there's 14 days or more have passed since that vaccination was administered in order for them to be considered up-to-date if they're COVID positive. If COVID positive doesn't play a part or a factor in it, they are considered up to date from the time that they get the vaccine. They did add a section called hospitalizations. So they were very clear to be careful not to confuse this with your new positive tests for the week. So this section, so you're going to have the section for positive tests. And if you've had any new positive tests since the last time you reported, you'll note that in the positive test. But then you're going to look separately, since the last time you reported, was anybody admitted to the hospital and have a diagnosis of being COVID positive? So if they were just admitted because they fell and they broke their hip or they had exacerbation of their CHF and that's it, they don't get counted. It's only if they're COVID positive and they were admitted into the hospital and their COVID positive test was within the past 10 days. The second question to that will be, were they up to date with their vaccination status? So that's kind of a repeat of what you did up above, keeping that 14-day rule in mind when you're answering that up-to-date status. And then when you go over to the next tab, the staff and personnel impact section, everything was removed, your COVID deaths, influenza, staffing shortages. The only question remaining is how many staff have tested positive since the last time you reported. The entire therapeutic section has been removed. So that's gone. And then I just also wanted to, with this question being asked, there was a lot of confusion during the training regarding the weekly reporting, because one slide said we were to report weekly, and another slide said we were to report 1 week per month during that month. So they clarified that to say we have to continue the weekly reporting through December of 2024. And then after that, at this point in time, now that's a far ways off, but at this point in time, they're predicting that then you will still have to report this information, but you will only have to report it 1 week per month to stay consistent with the reporting requirements. And Kathy will drop a link in the chat. They did also post, because that section went live this week, they did post the updated form and directions for the form. So we'll post that in the chat so you have that.
Thank you, Deb. The next question says, I know it's recommended to get 1 bivalent vaccine to be considered up to date. Is it recommended to be given on a yearly basis?
I can take this. So at this time, getting 1 bivalent vaccine is recommended for anyone over the age of 6 to be considered up to date. There haven't been any new recommendations or whether this will be made into a yearly vaccination, but I'm sure before fall, we're thinking there might be new recommendations coming out, and think it might become a yearly vaccination like the flu, but it's still to be determined.
Thank you, Shirley. Next question. Does the infection preventionist have to be an RN?
You're muted, Penny.
Yeah, I realized that. I'm sorry, I'm on mute. I can answer this question because I had this question come across, and I followed up with our wonderful IP, Jen Brown, who gave me all this information. And in fact, an LPN can be an infection preventionist. And actually, the infection preventionist doesn't even have to be a nurse. They could have training in other disciplines as well. And under F882 in the regulations, it actually states that while the facility does have to designate one or more individual as the infection preventionist, they can have primary professional training in nursing, medical technology, microbiology, epidemiology, or another related field, be qualified by education, training, experience, or certification, but they must work at least part-time at the facility and have completed specialized training in infection prevention and control. And I know the nursing home that reached out to me with the question, they were interested in whether an LPN could be their infection preventionist, and if they have that education and training, particularly in infection prevention and control, they can do so.
Thank you, Penny. The next question says, now that the public health emergency has ended, if a resident has a positive test, would that one positive test put us into an outbreak?
Yes, and I can take that one too. Again, another question from a nursing home that I had. And fortunately, PA HON 701-0606 came out June 6th with a definition of an outbreak in a long-term care facility. And it does say that greater than or equal to 1 facility-acquired probable or confirmed COVID-19 case in a resident, and greater than 1 probable or confirmed COVID-19 case in a healthcare personnel who was working in the facility while infectious. But now, I said facility acquired probable for the resident. Probable case is actually defined in the HON, and that's a person meeting presumptive lab evidence. So that means they detected the SARS-CoV-2 specific antigen in a clinical or postmortem specimen using a diagnostic test performed by a CLIA certified provider. And then facility, it says facility acquired COVID. So what that means for long-term care facility is that's a long-term care resident where the COVID infection originated in the nursing home. And it doesn't refer to like those residents who were already had a known infection when they were admitted to the facility and then were placed in transmission-based precautions to prevent transmission to others. And it does not include residents who were placed into quarantine on admission and then developed SARS-CoV-2 infection while in that quarantine. So you really want to make sure when and looking at the HON that you're paying attention to what some of those definitions mean. But yeah, it's because they had said if I have even one, could it be an infection? And it just depends on, you know, if they were within the facility, yes, they could be an infection.
Okay, thank you. And the next question is the COVID vaccine still mandatory now that the public health emergency has ended?
So with the ending of the public health emergency, so ended the COVID mandate, though long-term care facilities must continue to educate residents, resident representatives, and staff about COVID-19 vaccines and make sure they're offering the COVID vaccine to the residents, resident representatives, and staff, as well as completing the appropriate documentation for all of these educational activities. Although the COVID vaccine is no longer mandatory for healthcare staff, and I just pulled out some wording from the CMS final rule, and CMS says, in lieu of regulatory requirements, and as previously noted, CMS intends to continue support and encouragement for healthcare staff vaccinations through other mechanisms, including quality programs. We encourage individuals to stay up to date with their COVID vaccines in accordance with CDC recommendations. So I would encourage everyone to continue educating around the importance of getting the vaccine. As we go into the summer, we want to make sure that everyone remains up to date with their vaccinations.
Thank you. Next question says, we are attempting to implement enhanced barrier precautions in our facility. Should these precautions be utilized during care with all dialysis residents?
So there's still remains a little confusion around utilizing enhanced barrier precautions, and these precautions should be utilized during high contact resident care activities with residents who are infected or colonized with MDROs, have indwelling medical devices such as tracheostomies or central venous catheters, or if they have chronic wounds. So if a dialysis resident falls into any of these categories, then enhanced barrier precautions should be utilized during those high contact care activities. We just have to keep in mind that many dialysis residents do not have central venous catheters. Some do, some do not. So enhanced barrier precautions should be utilized if a resident has an indwelling medical device.
Thank you. So we just got a question in the Q&A that is related to the vaccine question that you were answering just a minute ago.
Mm-hmm.
It says, is it specified how often we have to educate and offer the COVID vaccine? If resident or staff refuses, should we offer again annually or more frequently?
So that's really interesting, and I have not come across any guidance. Maybe one of the other experts on the panel have come across guidance. I would think that you just need to document that you have provided education. I would say at least once needs to be included in that residence chart, just to make sure that you've provided documentation. I think we're going to have infection control focus surveys coming up in the second half of 2023. And I think that they're going to be looking for this documentation. So I would ensure that it is included in every resident's record.
Okay, thank you. And we have one more question here from our pre-submitted questions. So if anyone on the call today has a question they'd like us to discuss, this would be a good time to send it to us using either the chat or the Q&A tool. So this last question says, I heard there is a new HHS entrance worksheet. Is this true?
So yes, that is true. To stay in line with the updated regulations and the PHE ending, the entrance worksheet has been updated. So at the bottom of the form that you're using, you want to make sure that the date is June of 2023. Thankfully, there's been nothing new that's been added, but there has been some areas that have been removed. And I kind of did checks and balances and cross-reference. So the areas that have been moved is providing a list of COVID suspected and confirmed cases, staff responsible for your infection control program and your COVID vaccination efforts, staff responsible for notifying residents and their responsible parties for suspected or confirmed COVID cases, and those responsible for water management. It removed all items related to notifying residents and their RPs for suspected or confirmed COVID cases and testing for COVID. And it removed the requirement for Department of Health staff vaccination matrix. So I know I have gotten a lot of questions regarding, do we still need to do that staff vaccination matrix? It's kind of goes with what Jennifer has said in the past with screening and taking temperatures at the door. 1 minute it's listed and now it's not listed. I've asked a number of subject matter experts to see if we can get any clarification, and nobody will come outright and answer that question for us. But I can tell you it's no longer on the entrance worksheet. So I do know a number of facilities are stopping that. You still have your NHSN reporting, so you're still going to have, the vaccination status for your staff. So I would say follow your facility policy. It's just like the notifying residents and RPs of suspected or confirmed COVID cases. It may not be on that entrance checklist, but I'm sure they're still going to want to see that somehow you're communicating to your residents and visitors, what's going on in the building. So they're no longer on the entrance worksheet, but still make sure that you are meeting the needs for any other infection control regulations, and you're meeting what your policy states. So that's one thing that they've been very focused on, is just because it's been removed from a PA HON or a CMS QSO, if you still have it in your policy and that's what your policy states you're going to do, you still have to do it. So just make sure with any changes that you're doing as these regulations change, that you're making sure you review and update your policy and procedures. And I believe Kathy is going to drop that updated worksheet in the chat for you, so you have a copy of it.
Yep, that is in the chat now. We got a submitted question about enhanced barrier precautions. So I think this one's probably for Jean. If a resident has a pressure ulcer, but skin is intact, a suspected deep tissue injury, would enhanced barrier precautions still be required?
So the recommendations for enhanced barrier precautions is if there is for a wound. So it is assumed that the skin is not intact, that there's an opening to the skin. So if we have just a DTI where we have intact skin, then I wouldn't think in that case, then enhanced barrier precautions need to be utilized. I think that you have to be really careful, because once that wound opens up, and then enhanced barrier precautions are probably going to be indicated in that case. And then a lot of our residents are colonized, so maybe also look into that if there's any documentation you can find to see if the resident might be colonized with an MDRO, because then again, enhanced barrier precautions would apply.
Okay, thank you. And that's the last of the questions we've received so far. So I'm going to go over a couple closing items. If anybody else has a question, please submit it at this time using the chat or the Q&A tool, or you can raise your hand if you would like to ask your question out loud. I'd again like to invite everyone to next week's webinar, which will be on post-COVID syndrome with Dr. Storm, who will be presenting that day. And that webinar will be next Wednesday at 2 p.m., the same time and place as this webinar. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Those are basically like virtual office hours. Deborah Wright will be there to answer your questions on topics like quality improvement initiatives, infection control, or the MDS coding. You can find the links to those live chats and our webinars in the newsletter we send out each Friday called the Last Minute Lowdown. And if you would like to receive that newsletter but don't think you're on the mailing list, you can email me at caudill@qualityinsights.org to be put on that list. And let's see, we don't have any more questions so far. So let's take a moment if anyone on the panel has anything they'd like to add before we wrap up here. I'll give you a moment. And
I'll just remind everybody to be watching for their SNF Medicare claims audits. Every facility will be audited with 5 claims reviews. So just make sure you're watching for that. And those that are opening the mail, they know what to do with it when you get it. But nobody will be excluded from that. So that is a CMS wide audit. So I do know that those have gone out and some have started to receive it. So just make sure that those getting the mail for you are watching for that, and you guys take care of them.
thank you, Deborah. Okay, well, I'm going to go ahead and wrap us up if that's it for questions. Before we sign off, I'd like to ask everyone here to please answer a short evaluation of today's webinar. It is anonymous and will show us a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. I'd again like to thank our panelists for joining us here today and to thank all of you for joining us. And we hope you can, I was going to wrap up. We got one more question that came in. Do you have any clarification regarding PPD versus staffing ratios? Is the staffing ratios based on the whole facility census or by unit only?
Yeah, so I can take that. So we did have a webinar yesterday where Paula Sanders talked. We've gotten some feedback from presentations that Susan Williamson has done for the state of Pennsylvania. And it is facility-wide for those ratios with the disclaimer to make sure that you are still meeting the needs of the residents. So if the ratio is 1:12 and you have a unit that has 15, just make sure that the needs of those 15, if you only have 1 staff member on that unit, is still being met. So you have to, they're saying, make sure you're looking at your facility assessment, the needs of the resident on that unit, and taking all of that into consideration. But from a purely number standpoint, they're looking at the facility as a whole.
Thanks. And just so anyone who couldn't make that webinar yesterday, I went ahead and dropped the link in the chat for our website where you can find that recording for that webinar if anyone, any of these Pennsylvania facilities are interested in seeing that. Okay, so back to wrapping up. Hopefully, that said, if anybody does have any last second questions, I could put the brakes on this again. Okay, again, before we sign off, we'd like to ask everyone to answer that short evaluation if you have a couple minutes. I'd like to thank all of our panelists for joining us here today and thank all of you for joining us. And we hope to see you all back here again next week.